Welcome, everyone. My name is Amanda Knepp. We are pleased that you could all join us for this week's lecture in Volume 4 of our No Neuroanatomy Didactic Series, which brings you lectures from experts in the field covering different topics each week. This series was created by trainees and early career neuropsychologists, including standing members of the No Neuropsychology Board, as well as members of the No Neuropsychology Committee. Before we start our lecture, one of the main goals of No Neuropsychology is to provide free, high-quality didactic content to our audience. Every No Neuropsychology and No Neuroanatomy lecture is available on our YouTube channel. Be sure to check it out, subscribe, and like our lectures to get first access to new content. Additionally, No Neuropsychology works to bring you learning and discussion questions that are provided with each specific lecture's content. You can access these on our website. Here are the disclaimers for the series. This training is not meant to replace formal education in neuropsychology, and the views of the speakers are their own. Questions can be submitted via the Q&A box on the lower left of your screen, and a recording of today's lecture will be provided on our website and YouTube channel later this week. Now it is my pleasure to introduce Dr. Alec Neal for today's lecture titled The Thalamus, a Nexus of Sensory, Motor, and Cognitive Function. Dr. Alec Neal is a clinical neuropsychologist and assistant professor of neurology at Yale University's School of Medicine. He earned a PhD in clinical psychology from Rosalind Franklin University of Medicine and Science. He completed his predoctoral internship at The Ohio State University and postdoctoral fellowship at North Shore University Health System, Endeavor Health. Dr. Neal's training and clinical practice includes work with a diverse range of adult neuropsychological populations. He specializes primarily in the assessment and management of individuals with movement disorders, including conducting pre-surgical evaluations for deep brain stimulation. Dr. Neal's research interests broadly encompass the predictive utility of psychological and cognitive variables on post-intervention outcomes, such as neuromodulation and bariatric surgery. Please welcome me in joining Dr. Alec Neal.
Thank you very much for that introduction. Let me make sure okay. Everything look good? Yeah,
Looks great.
awesome. Okay. Thank you for that great introduction. And thank you to all the folks at No Neuropsychology. It's an honor to be presenting here. As I found these presentations really helpful when I was coming up as a student not too long ago. And also shout out to all of the people who have joined for a late Monday afternoon talk about the thalamus, um, which is a fairly heavy topic. But I was sort of initially thinking of ways to loop in other regions or sort of really specific clinical syndromes. But I realized I personally never saw a didactic or presentation about the thalamus. Um, so I thought that may be the case for others as well, and it sort of deserves its day. Um, so that said, it's a pretty complicated region with a lot of individual subregions with complicated names and functions. Um, so may not be the most riveting topic, but hopefully it can serve as a nice introduction to the thalamus and a sort of potential study guide for things like board prep. Um, so the title is The Thalamus, a Nexus of Sensory, Motor, and Cognitive Function. A nice excuse to use the word nexus because I think that's a really cool word with a nice sci-fi vibe to it, which tried to tie in elsewhere, as you will see. So, Um, we'll start off with a quick case to illustrate the importance of the thalamus. So imagine a 59-year-old patient wakes up unable to feel the entire left half of their body. This could mean a lot of things, but interestingly, the MRI is not showing any cortical damage. Nothing extreme on the MRI. So, but it turns out there's a sort of deep injury in the brain. So the culprit is a lesion in the right thalamus, which has disconnected sensory signals from reaching the sensory cortex. So this really dramatic deficit of losing feeling on one entire side of your body from a really small, deep stroke, I think highlights um, the thalamus's role as a gatekeeper for information flowing to the cortex. So in sort of one line to summarize the thalamus, it's a relay and control center through which all sensory and most motor and modulatory signals must pass through to reach the cortex. So every sensation except for smell and many of the motor and limbic signals are processed in the thalamus, and that makes it an indispensable region for conscious perception. So throughout this talk, we'll connect how the thalamus's anatomy, its nuclei and connections, sort of explains its outsized influence on behavior and clinical syndromes. So first we'll sort of get oriented here. So each thalamus is about 3 centimeters, and it's an ovoid shape. There are two, one per hemisphere, and they lie deep in the center of the brain, constituting the bulk of the diencephalon, which is the thalamus, epithalamus, and hypothalamus. Um, so as you can see, it's sort of right in smack dab in the center here. Um, and it's surrounded by a lot of other important areas. So it's perched right on top of the midbrain, and it's bounded laterally by the internal capsule. So, as you may know, the internal capsule is what carries all the fibers between the cortex and subcortical structures. Um, so it wraps around the sides of the thalamus, and it's sort of used as like a landmark for surgeons. Um, and anteriorly, the thalami are near the interventricular foramina, and they medially, the thalami flank the third ventricle. So the third ventricle is right in between the thalami. Um, and so it sort of presents as an inverted V shape. So they're sort of pointed outward. So on like horizontal sections, on like neuroimaging and things like that, um, it's sort of a V-shaped area. Um, so now we will get into some of the nuclei. So there's dozens of nuclei in the thalamus, each with specific connections and functions. I'll mostly be referring to the nuclei by abbreviations, because saying the full name would add a lot of extra time to the talk. But I will try to call them out at least once each time. But that said, the abbreviations are pretty intuitive, so they mostly mean exactly what you would guess they would mean. So referring to like dorsal, ventral, anterior, posterior, lateral, medial, um, mostly a combination of those letters. Um, and so there are a ton of subdivisions and ways that people have sort of presented how they're divided up, in like hierarchical ways. Um, but a pretty common way is the based sort of on the key landmark of the internal medullary lamina. So that is this myelinated sheet that branches into a Y shape on axial sections. It partitions the thalamus into anterior, medial, and lateral groups. So we can consider all of these things lateral groups, but for my purposes, I'm sort of dividing up the lateral group a little bit. Um, so the anterior nuclear group is pretty straightforward. It sits in the fork of the Y of the lamina, and the medial group has the medial dorsal nucleus, and the lateral group has um, sort of the dorsal region, which is the pulvinar nucleus. And it has all these ventral tiers and also the lateral regions. So there are also some sort of bonus groups. So there's the intralaminar nuclei. Um, so those are not in this picture, but I have a picture coming up that highlights those a little bit. So they're just tiny nuclei embedded within the lamina, um, and they're they have like diffuse projections for arousal and motor loops. Um, Wrapping the lateral surface is the thalamic reticular nucleus. So that's like a GABAergic sheet of um, cells that regulates thalamo-cortical traffic. And there's also the stratum zonale, which is a thin layer that's on the superior surface instead of the lateral. And there is the intrathalamic adhesion here, which is um, bridges the two thalami through the third ventricle. And interestingly, it a lot of people don't actually have one, so the sort of function of it is up to up for debate a little bit, but it's assumed to help with communication between the um, two thalami. Um, but I think it's around like 25% or so estimated. But it's more common in males to not have the intrathalamic adhesion. It's also called the massa intermedia, if you've heard of that term before. So basically, the takeaway here is that the thalamus is highly organized into all these nuclear sort of groups, and the groups have sort of specific cortical partners and functional roles. Um, So these I'm not going to go over, but this is a really sort of thorough version of all the main inputs, outputs, and proposed functions of all the nuclei, like the primary nuclei. But I will just pause on them real quick in case people are watching this back and they want to um, pause to study these. So I have with um, some inspiration with from some friends have invented a little bit of my own grouping layout that could potentially make learning this a little more fun if you are invested in learning about the thalamic nuclei. So this is based on Thanos because it sort of sounds like Thalamus, Thanos. It's got the sort of Greek roots. Um, so this is based on the Infinity Stones, and there are six of those that Thanos collects, and they all are different colors, and they represent um, different things. So soul, mind, space, power, reality, and time. And those sort of words do in a lot of ways line up with some of the functions of the thalamic nuclei. Um, so we have the anterior group, which is just the anterior nucleus, and that's important in memory and emotion. It's part of the PAPE circuit. So we can think about that as sort of the soul, because it's, involved in emotion and memory. Um, we have the medial groups, um, which we can think about as the mind, because these are involved in executive control, working memory, and affect through prefrontal cortex loops. We have the lateral groups, um, which for my purposes, I'm considering these more dorsal ones and the pulvinar. So those are to represent s the space stone, and function have important functions in visual attention, spatial integration. We have the lateral group, ventral tier of that. So all these regions down here, um, the ventral anterior, ventral lateral, ventral posterior, posterior lateral, and ventral posterior medial. So these are to be representing the power stone. So that's for they're involved in motor planning and feedback. They're also involved in all the sort of body and face somatosensory relay, so it doesn't 100% line up with just like motor sort of power, but um, take it or leave it. Then we have the lateral group, which the lateral group metathalamus aspect. So that's these lateral geniculate nuclei and medial geniculate nuclei. So those are the reality stone. And as these are really sort of, I'd say, the more well-known nuclei. Um, because anytime anyone's talking about the visual or auditory pathways, these are the thalamic nuclei that get brought up, so they're important in those senses. And lastly, we have this last grouping, which is just sort of a hodgepodge of other things, such as the intralaminar nuclei and the thalamic reticular nucleus, which again is that sort of sheath that covers the whole lateral surface. Um, and that's to represent time. So it's um, these are both of those that I mentioned are involved in arousal and the reticular activating system, attention gating, sleep rhythms. So these are sort of consciousness slash wakefulness areas. So sort of goes with time a little bit. So hopefully that helps out at least one person that wants to really get into learning the thalamic nuclei. Um, so again, we have this thalamic reticular nucleus, which is this sheet across the side. Okay, so we will get into some of the specifics here. So these slides are probably too wordy and dense, but can be helpful to review. But I'm not gonna sort of walk through every um, aspect of every connection. But generally speaking, the LGN and MGN are special sensory relays for vision and hearing. So LGN, you can think lateral equals light, and light refers to vision. So the LGN receives input from the optic tract, and it projects to via the optic radiations, which are like represented here, um, to the primary visual cortex, and then there's a attention, visual attention like feedback that occurs as well. Um, so an isolated LGN lesion, which you can think about as being like here, this is supposed to sort of represent the um, thalamus connections. So an isolated lesion there would result in contralateral homonymous hemianopia with a spared pupillary reflex. So these um, representations. And the MGN, you can think medial equals music. And so music refers to sound. The MGN receives input from the inferior colliculus and projects to the primary auditory cortex. And unilateral lesions here um, don't cause like complete deafness. It's usually more subtle deficits in hearing. Um, and there's it's the MGN's like tonotopically organized, so it um, depends what part of the MGN is damaged will affect hearing for different frequencies. Um, and but there's thought to be involvement of the MGN in sort of other disorders, so auditory processing disorders and even tinnitus are um, thought to involve the MGN. Um, and just a quick note that both the LGN and MGN are modulated by the thalamic reticular nucleus and cortical feedback to tune the sensory sort of throughput into the thalamus. So gating how much and what kind of senses are allowed through. And again, olfaction sort of uniquely bypasses the thalamus initially. Um, then we have um, some of these motor loops. So the ventral anterior and ventral lateral nuclei. Um, so the ventral anterior nuclei receives basal ganglia output and sends it on to premotor and supplementary motor areas for initiation and program selection of movements. The ventrolateral receives cerebellar input and can get input from the basal ganglia as well and sends it to the primary motor cortex and premotor areas for sort of timing and coordination of movement. So um, sort of similar functions, but sending them to um, slightly different cortical areas and involved in different loops. So we have the cortical basal ganglia thalamic cortical loop and the same, but with the cerebellum. Um, so there's also the ventral intermediate nucleus. So that acts as a critical relay station in the cerebello-thalamo-cortical loop. So passing information from the cerebellum and transmitting it to the motor cortex. And so sort of related to a central tremor, it's hypothesized that the VIM not only sort of passively relays this information, but actively facilitates the propagation of like tremor related signals. Um, so in folks with essential tremor, it's thought that this relay is altered and the thalamus potentially acting as a filter that fails to sort of effectively regulate or suppress the abnormal rhythmic activity originating from the cerebellum. Um, and so together, the VA and VL, they sort of close these important loops. Um, and lesions in these regions can cause a lot of motor and movement symptoms, such as ataxia, bradykinesia, tremor, and sensory motor deficits as well if the internal capsule, right, sort of next to it is also involved. Um, so it's generally speaking, sort of really specific focal injury to these thalamic nuclei do occur, but a lot of times this is in the context of it depends on sort of the etiology, right? So if it's a big PCA stroke, then it's not just going to be one thalamic nuclei. So in that sense, it's sort of rare. It's more common to have more than one region that's impacted in the actual clinic. But they do have their own vasculature and things like tumors and things like that can get specific at times. This other of the power stones here is the somatosensory relay group. So that's the VPL and the VPM. The VPL handles the body sensations. So that's via the medial lemniscus and spinothalamic pathways. The VPM handles the facial sensations um, through the trigeminal, and it also handles taste sensation. Um, both of these project to the primary somatosensory cortex um, at the appropriate um, area for that region. So the VPM goes to the face, and the VPL is going to the body. Um, and also the oh, and the taste sensations end up in the insula. So over here. Um, so the somatotopy is preserved, aligning with the specific area that is innervated by each of these regions. So this image is way too small, but um, this is the VPL and VPM down here. So we're getting these inputs from the different sensory pathways, which are being passed on to the same primary somatosensory cortex, but in different somatotopic areas of it. And then this sort of dreaded figure is just to show sort of this is the thalamus here, and that the VPL and VPM are sort of the areas that are getting this sensory information up to the cortex to be sort of perceived and acted upon. Um, okay, and then here's where the stones analogy sort of falls off the rails. Um, but I think it's easier in this case to talk about some of these areas as sort of just general association and limbic nuclei. So we have the medial dorsal, pulvinar, and anterior nuclei. Um, so these all sort of play roles in cognition and emotion. So the medial dorsal, um, which is this, integrates limbic input. So from the amygdala and olfactory, with executive control. Lesions here can cause working memory, planning, and motivational deficit. So sort of that executive dysfunction pattern. Um, but bilateral lesions in the medial dorsal nuclei can cause like sort of profound amnesia. Um, the pulvinar links um, the visual colliculi and parietal temporal association cortex. So again, the pulvinar is related to sort of visual attention and multimodal integration. Um, and lesions can sort of present uh, as like issues with visual search or neglect like looking profiles, but not from a cortical issue. So the anterior nuclei, lastly, is the one that participates in the Papes circuit. Um, so the soul stone. So that's the circuit that's highly important in memory. It's the mammillothalamic tract and cingulate sort of loop, and lesions in the um, anterior nucleus cause anterograde amnesia, disorientation, and this is the same presentation as you see in like Wernicke-Korsakoff syndrome, which also is involving the mammillothalamic tract. Um, and so sort of severe amnesia, but with that sort of confabulation type of issues, misremembering source memory errors, um, but also in the context of like dense amnesia. Um, and also interestingly, the anterior thalamus has been explored as like a DBS target in some conditions like Tourette's syndrome. So we'll discuss a little bit about DBS because some of these nuclei have been used as DBS targets. Um, one in very particular, but there's several that are implicated. Um, so here we have the arousal and regulatory nuclei. So these are some of the random ones and the midline area. So these are all regulators of arousal and gating. So these, I think, reticular activating system, arousal, consciousness, sort of functions. So the intralaminar nuclei um, receives information from the ascending reticular activating system, um, and as well as pain collaterals. And it projects diffusely to the cortex and striatum of the basal ganglia. Um, Bilateral damage in the intralaminar. So those tiny little nuclei embedded within the lamina. If there's bilateral damage in those, it can result in coma. So these tiny little zones are very, very important. Um, the midline nuclei over here work with the intralaminar nuclei for sort of arousal and limbic coupling. So like emotional salience related to arousal. Um, and the thalamic reticular nucleus, so the sheath again, um, it forms an inhibitory shell, sort of covering the thalamus. Um, so it sort of samples all the thalamo-cortical and cortical thalamic signals, so a lot of the signals coming in and out of the thalamus, um, and sends GABAergic inhibition back to the relay nuclei. And this um, results in setting sleep spindles for sleep and is relatedly relevant for attention and focus. But it's also important in gating sensory information that comes in, which, as we know, is more or less sort of taken in when we're sleeping or when we're falling asleep. Um, so dysfunction in the TRN is has been associated with lots of different things, but particularly absence seizures, but also like attention disorders, which makes sense in both cases, sort of arousal and attention. Um, okay. Um, so like I mentioned, there's can be different reasons that the thalamic nuclei are damaged, whether it's focal or not. A lot of times it's not focal, but it can be. So they're major cause of issues with the thalamus are vascular in origin. So it's the predominantly the posterior circulation. It's the PCA and posterior communicating artery perforators. Um, so we have all these sort of subsections of perforators that go to different aspects of the thalamus. Um, so I won't sort of read them all off, but they're listed here. So they certain um, branches reach different aspects of the thalamus. But also if there's just a general PCA issue or a basilar artery issue, that can also impact the thalamus. Or you can have a um, much smaller lesion, but it causes a lot of issues if it's at an important part of the thalamus. Um, so, so the blood supply is crucial to understanding thalamic stroke syndromes. Um, so I think the next slide talks about that. Um, yeah, that's all I'll say on this one. So thalamic stroke syndromes, can be, as I sort of referenced in that initial um, quick case example, a thalamic stroke can be small and but pretty impactful. Um, so there are generally like distinct territory syndromes when it comes to thalamic strokes. Um, so like the anterior, like a stroke in the anterior nuclei due to a occlusion of the tuberothalamic. Um, Perforations are can result in thalamic aphasia, um, which is a sort of uh, specific presentation of aphasia. Um, it can also result in amnesia, disorientation, um, and as well as apathy. So apathy is like a common profile across a lot of the thalamic stroke syndromes. And the whether or not language is affected at all depends on the laterality. So if it's on the left thalami, assuming left language dominance, then there will be some effect on language, or perhaps more verbal memory versus visual memory in certain areas. So, for example, we also have the paramedian nuclei, which, um, if affected by a stroke, can result in decreased alertness or coma if it's bilateral. Um, And again, um, if it's on the left side, there can be issues with language. Um, but those are a little more transient most of the time. So if we're in the ventral areas, from the inferolateral vessels, you can have the contralateral hemisensory loss. So that's that first case example, that's pure sensory stroke. Um, can also result in um, motor issues too, so possible ataxia and a risk of thalamic pain, which I will talk about on a later slide. Um, the pulvinar and LGN regions can be impacted more specifically as well, and that can result in visual field deficits um, and possible sort of sensory motor signs as well. Um, so these different patterns that can emerge sort of highlight that there's a lot of structure function mapping that happens in the thalamus, um, and overarchingly important to think about in terms of how other like neurodegenerative conditions can sometimes have similar symptoms to these. Um, but a small stroke in one part of the thalamus versus another can s suddenly look like um, a presentation of a different neurodegenerative disorder. So important to note that sometimes really small issues can cause big symptoms. Um, so a little bit more pictures of the vasculature. So this is just to highlight that the posterior cerebral artery is what's going to the thalamus. This is the thalamus here. Um, and just to note this, artery of Percheron is an interesting sort of abnormality. So there's this certain variant that exists in about 5 to 15% of the population it's estimated at, but those estimates can be higher depending on samples that they're looking at. So it's this type 11B variant that is considered the artery of Percheron. So it's when there's only one branch coming off the PCA, but it um, goes to bilateral thalami. So it's like a sort of risk condition when you think about it, right? So if there's a stroke here, then it suddenly affects um, the bilateral thalamus, which in some cases, as I mentioned before, bilateral damage can have a much bigger impact than unilateral damage. Um, and so generally the symptoms of in AOP stroke is acute hypersomnolence. So basically falling asleep, and as well as a vertical gaze palsy, like in progressive supranuclear palsy, and amnesia. So a lot of um, interesting symptoms can emerge when this happens. Uh, how am I doing on time? Yeah, I might skip this slide. So sort of the overarching summary here is that every cortical area has a thalamic partner to it, and the connections are reciprocal. So we have the sensory streams, except for olfaction, that pass through the thalamus to the cortex. And then we have the motor loops that rely on the VA and VL regions to return to the basal ganglia um, and cerebellar or pass basal ganglia and cerebellar information onto the cortex. We have the limbic memory circuit that runs through the anterior thalamus, and the medial dorsal links to the um, frontal cortex, and then we have those arousal regions, so the intralaminar and midline regions, and similarly, but somewhat different, the thalamic reticular nuclei, important for attentional rhythms. Um, and so the thalamus just it sits at the center and synchronizes cortical activity and is, as you might imagine, makes it very key for consciousness in general. Um, as some people understand consciousness. Um, I'm going to skip this case because we talked about that already. But so like a thalamic lacune can essentially um, often can result in sensory loss because it's so essential for somatosensory information relaying. Um, yeah, that's all I'll say about that one. But here's another interesting sort of mini case example. So you could imagine a this being a say 70-year-old man, and this is 6 months after a right VPL stroke. And now suddenly he's having constant burning pain and allodynia on the left side of his face, his arm, and his leg. Um, and so that's what's referred to as Dejean-Roussy, or thalamic pain syndrome. Um, so the mechanism of what causes this is deafferentation of um, the sort of thalamic connections um, from the stroke, and then things maladaptively reorganize around that deafferentation later on, and then so there's often a delay, but then later on, the thalamic regions are hyper excitable because they lost um, so many connections that suddenly um, doing nothing becomes painful, or the allodynia is when there's um, things that aren't typically painful become painful. So just like brushing your fingertips on the skin is painful. So it's essentially a loss of sensory gating that's happening. And it's somewhat common in stroke. But it's higher in folks with thalamic stroke, and it's often a delayed onset, and it doesn't have to be the entire body, but this is something that once you know about it a little bit, you'll start noticing it in stroke patients if you see them once in a while or if you see them often. Um, so some management considerations here are medications, sort of neuropathic agents like SNRIs and gabapentin. So sort of those nerve pain medications. And but in like refractory cases where they're pretty severe, um, DBS or spinal cord stimulation has sort of been explored as an option. So going to the BPL. And quick other mini case sort of highlighted this already, but um, a if somebody presents with like acute disorientation and forgetfulness, slightly worse for verbal over visual information and confabulation, and mild word finding issues, or naming issues. Um, then this could, for instance, be a stroke affecting the anterior nucleus or MTT, mammillothalamic tract, which goes to the anterior nucleus. Um, yeah. So it's that same as Korsakoff's presentation, with the amnesia, confabulation, and sort of milder language-related issues. Okay, so I've blabbed a ton of big words that I've mispronounced and stuttered around because they're very hard to say no matter how many times you've read them. Um, but what's the sort of big picture of some of this stuff? So um, essentially, again, thalamic lesions can produce different types of neuropsych relevant presentations. So if there's left-sided thalamic lesions, there can be thalamic aphasia. It's rare, but to have a sort of pure thalamic aphasia, but can present with like problems in naming fluency, dysarthria. So all those um, features of that can be present in aphasia. Um, Memory issues, like in the last case, um, especially in um, the medial dorsal and anterior regions, can result in significant memory issues, anterograde amnesia. And then just generally speaking, if you're thinking thalamic stroke, it's sort of that subcortical cognitive profile you would expect. So executive slowing and apathetic presentation. Um, Also, there can be sort of cumulative small strokes that occur in and around the thalamus over time, and those can sort of culminate in a general subcortical cognitive syndrome or thalamic dementia, and that's just sort of global cognitive slowing, so significant processing speed issues, um, as well as the sort of other things you would expect to come with that, which might be executive functioning issues and apathy. Um, and then there are also psychiatric um, relevant things that can come up with thalamic lesions. So, for instance, the medial dorsal and intralaminar abnormalities have been implicated in schizophrenia for issues with like gating sensory information, and um, so think like hallucinations, um, and as well as ADHD. So sort of gating attention. Um, and so also there are the sort of therapeutic things related to the thalamus. So we have DBS targets, which include the VIM for tremor. Oops, there is a typo there. Um, and the anterior nucleus for epilepsy has been explored, and also the central median nucleus for generalized epilepsy, disorders of consciousness, also investigational, and the medial dorsal in research for Tourette syndrome and obsessive compulsive disorder. So this is uh, sort of DBS in general is spends a long time in research, but there's always a lot of new interesting targets and things that are happening in um, that literature. And wouldn't be surprised if there's sort of, mm, even though that's traditionally been something focused on in like movement disorders and epilepsy, there's a lot of like more psychiatric exploration in recent years there. And a lot of it is related to the thalamus. Um, so wrap up is again, thalamus is the cortex's gatekeeper and integrator. Um, so there's sort of obligatory relays that happen with sensation, and there are territory-specific syndromes that can occur. Um, yeah, so they're yeah, sort of covered all these things a lot, and don't want to save some time left. And here's just another good image that highlights, and these are just the thalamus cortex linkages. So there are lots of other connections with subcortical regions, but this, especially this one here, is highlighting where all the outputs are ending up, and it's basically all over the cortex. So it's sort of like a mini brain in a way. Um, and then sort of the meta picture um, for neuropsychology is that first, I think, neuroanatomy knowledge helps us with differential diagnosis. So it's, it's like I mentioned earlier, it's important to know that even though something looks like um, Korsakoff syndrome or it looks like Alzheimer's disease because it's just sort of severe amnesia, it can be a thalamic issue, and almost any symptom can be a thalamic issue. So it's important to know that, and at the same time, um, it makes the thalamus like a great gateway to learning neuroanatomy. Um, so understanding the thalamus because it's sort of involved in everything in certain ways, um, makes you understand all the cortical regions it goes to a little bit better. So it's pretty dense, as I'm sure everyone's aware now. But I think it's a good region if you're trying to dig into neuroanatomy to understand. And so, for example, if neuroimaging is not available for a patient, it's still important to sort of understand the trajectory of symptoms, because, like I said, it could be, a small thalamic stroke potentially, versus a neurodegenerative condition, or it could be other syndromes. So autoimmune diseases can sort of affect the thalamus too. Um, lots of things can affect the thalamus, but on a more focal level, it's usually the strokes, as we've discussed a bit. Um, and at the end of the day, I think um, it's um, important for us to lean into the psychologist role, because differential diagnosis sort of remains important now, but it's going, I think, in my opinion, will become like increasingly less important. So even though I just yapped about neuroanatomy for 50 minutes, I think it's not not essential to know every single nuclei and things like that. It's essential to know that you should look for that information when certain symptoms come up. But generally speaking, I think our role as the person adding a diagnosis will sort of get smaller and smaller over time, not just because other specialties will do it, just because of technology and biomarkers and things like that advancing. Um, so um, I think it's important that some of the things that I feel like are less likely to diminish over time um, are sort of perspective on the patient, where we understand um, and can empathize with patients' actual experience of the symptoms instead of just adding the diagnosis based on the symptoms. So spending a lot of time with our patients to understand them from sort of top down and bottom up angles, whereas a lot of specialties might do completely sort of bottom up or just have not as much time to visit with their patients to sort of understand the whole context of things. Um, and so that I think will continue to give us a unique opportunity to induce change in a patient's trajectory and still offer a sort of different perspective to referring colleagues, regardless of whether it's telling them we think this patient had a thalamic stroke, because that's, not something we'll necessarily be involved in. Um, but still important to know that. Okay, so I probably went way over time here. Here's some references. And thank you again.
Thank you so much for this informative lecture. Those explanations of the differential impact of specific lesion locations were super clear, and I know that Thanos analogy will really stand out and be helpful for people.
Even if it's just one person, I'll take that.
So thank you so much. Unfortunately, we don't have time for any additional questions, but we really appreciate you performing this lecture for us. I know this summer I learned so much about neuroanatomy. So everyone, I hope that you'll join us again for the next No Neuropsychology series in a few months. Until then, have a great evening. Take care.